Are you ready?
Yes, ma'am.
Are the presenters who will present the case?
जी मैम.
Structure discussion करना चाहेंगे या teaching station? Because this uterine inversion came as a teaching station or as a structure discussion.
टीचिंग मैं कर लेती हूँ.
चलें start करें. Okay, Dr. Lubna,
जी जी.
you are the student, okay?
Okay.
Assalamu alaikum. My name is Dr. Nazish Fatma. I am a senior trainee here, and I have come to know that you are here to learn about the uterine inversion, the management. Is this correct?
Yes, doctor, this is correct.
Okay. Okay. Tell me, what is your name?
My name is Lubna.
Okay, Dr. Lubna. How's your training going?
It was good.
Okay, and is there any problem in the ward, or is everything okay? Okay.
No, my training is going fantastic and everything is okay in my ward.
Okay, very good. Okay, Dr. Lubna, tell me, why do you want to learn about this specific topic, and in which areas you want to learn?
Actually, I have a I have a seen an obstetrical emergency that was coming out in a labor room last week. Then, but unfortunately, I at that time I have no idea about uterine inversion. So I think this is obstetrical emergency, and I must learn. That's why I came here.
Okay. Okay, tell me, what do you know about the uterine inversion?
Uterine inversion, I think this uterine inversion is when the uterus is turned inside out when we are removing the placenta at that time.
Okay. Right. Okay, I will teach you about the inversion, uterine inversion, and its types, and then its management, its differentials, and its complications, and postnatal management, and in the end I will send you some videos and links so that you can have better idea about this specific topic. Okay.
Okay.
Basically, uterine inversion is a obstetric emergency in which it is in the third stage of labor, in which the uterus is turned inside out, and then it's an obstetric emergency, and the and we approach it through our team, and first of all, as it can lead to neurogenic shock, so after the resuscitative measures, after resuscitative measures, in which we insert 2 wide gauge IV lines, and giving the 1 liter normal saline, and if heart rate is less than 60, then atropine and analgesia and uterine relaxants are given, and then uterus is corrected, uterine is inverted back its normal position by making a cup and holding the fundus like a cup, and making and through the your thumb anteriorly and your fingers posteriorly, and with the right hand you insert the uterus back to its normal position, and this is called Johnson's method. And if it does not and also before that we shout for help, and we inform the senior obstetrician and anesthetist, and then and senior midwife should be there, and then uterus is inverted back, and if the Johnson method is not successful, then we proceed to Ussilman's method, in which vacuum is attached with the 1 liter normal saline, and making the C with the left hand on the introitus. We try to correct the uterus and put back its normal position with the right hand. and with the cup, silicone cup of the vacuum, and the distance should be 1 to 2 meters, and over 15 to 20 minutes 2 liter of fluids is given. 90% uterine inversion is corrected in this method. Are you getting my point?
Yes, I'm getting your point.
Okay, what are the methods? I have told
you have told about Johnson manure, and the other one is the O'Sullivan procedure.
Very good. You are very good learner. Okay, and now if this does not succeed, then we shift the patient to operation theater, and then after anesthesia, patient is given vaginal maneuvers are done, which are Spinelli and Costner's method, in which uterus is giving incisions on the anterior and posterior colportion is done, and the fundus is fundus is reverted back to its normal. And if both of these procedures are not successful, then combined abdominal-vaginal approach can be used to revert the uterus to its normal position. And in the end, if all of these procedures are failed, then we proceed to hysterectomy, and it is done in less than 1% of the procedures. To the less than 1% of uterine inversions. So far, I am clear.
Yes, doctor.
Okay. In how many? What is the percentage of hysterectomy in uterine inversion?
Less than 1%. Less than 1%.
Very good. Very good. You are a very good learner. Okay. After that, the patient is post-operatively, patient is shifted to the recovery, and close monitoring will be done for, and patient is enhanced recovery program will be given, where patient will be given analgesia, antibiotics, VT assessment. Patient is debriefing is done, documentation, and then patient is discharged with the red flag signs, and also after counseling for the recurrence, and the red flags and discussions and drills will be done, and she will be consulted for the 6 weeks follow-up and early booking in the next pregnancy. Okay.
Okay, thank you.
And what are the differentials of uterine inversion? I will tell you. It is the uterovaginal prolapse. Okay. And it can be a polyp, fibroid uterus, and undiagnosed second twin. Okay. Tell me two differentials of the uterine inversion.
These are uterovaginal prolapse, or the second twin, or some tumors.
Right. Very good. Okay. What are the complications of uterine inversion? I will tell you. It can be postpartum hemorrhage, and sloughing of the endometrium, or pulmonary embolism or uterine sloughing, and neurogenic shock, death. Okay. These are the complications. I want to tell me, how was the session?
Session was good, but I think you should take some pauses. Madam will give you feedback.
Okay.
You have 1 minute left. That's why I was quiet, so that you can complete your time.
Madam, I want to attempt it again. Can I?
Yes, sure.
Okay. And now, who is PGR1 for me?
Okay, I will become.
Okay. Assalamualaikum.
Walaikum salam.
I'm Lubna. How are you, and what's your name?
My name is Nazish.
Nazish. Okay, Nazish, I can see that you are here to learn about uterine inversion. Is it so?
Yes.
Okay, can you please tell me what is your main concern to learn this?
I want to learn about the management of uterine inversion because I have seen a case of uterine inversion yesterday, and
Okay, that's good. That's a great initiative. Okay, do you have any idea about uterine inversion?
yes, I think it's a obstetric emergency, and in which uterus is inverted inside out, and it's and I saw so many seniors coming in the labor room, so
Okay,
I
okay,
want
don't
to
worry.
learn about it.
We will together learn it, that what is uterine inversion and how we are going to manage it. But before this, we will set our agenda for our today's session. That what is uterine inversion, what are the causes, how we are going to manage it, and what are the complications of it. Okay, and at the end of the session, I will also give you some video links and some links of CPT workshops and better understanding. Okay,
Okay, thank you.
now good. Uh, that could be a one cause. When there is a placenta, eclita is there, or sometimes when we have used a magnesium sulfate. Can you repeat it one for me?
It is excessive fundal pressure, use of magnesium sulfate, and short cord, and
Okay.
uterine
Very,
eclita,
very good.
eclita.
Very good, very good. You are a very good learner. And now next comes the how you are going to diagnose a uterine inversion. You know, it's an obstetrical emergency. When we are delivering a placenta, sometimes a uterus comes with the placenta. And when you are going to examine your patient, you will see that her patient is in the hypotension, but at the same time, bradycardia is also there. You can see that the uterus is in turn inside out along with the placenta. So when you do the abdominal examination, you didn't find a fundus of the uterus in the abdomen. Are you getting it?
Yes.
Okay. Next comes, as you know, in every obstetrical emergency, what we will do, our first step is call for help. So similarly, when you find this emergency, what will be your first step?
Call for help.
That's good. And for the management of this, our resuscitation of the patient and management of the prolapse will be go side by side. You will be having a team with you. So some of the team members will maintain the airway, breathing and circulation. And at the same time, when there is a bradycardia, sometimes we need to give atropine to the patient. Okay. Can you repeat it for me that which drug we have to give?
Injection atropine is given to raise the heart rate.
Okay, that's good. Next comes the how we are going to manage the uterine inversion. For the management of the uterine inversion, as you can see, when the fundus of the uterus is coming outside, you will hold it just like a cup with the fundus in your palm, and then with the thumb on the anterior side, and your fingers will be on the posterior side. So with the help of your fingers, you are going to apply a digital pressure at the cervico-uterine junction. It will help in the cervical dilatation. And then as you can see that this is a fundus, and I am holding it just like a cup, and I am applying pressure with the help of my digits of my fingers. And then we are going to pass the uterus from the cervix until the uterus is inside the abdomen. Then you will make a fist and you will hold the uterus inside it till the uterus is contracted. So once the uterus is contracted, this is the time we will start the symptom. Are you with me?
Yes, yes.
Do you have any question? Can I repeat for you?
No, thank you. I am understanding what you're saying.
That's good. And you know the thing which I have told you, we called it as a Johnson procedure. 50% of the cases, our first step when we are going to reduce the uterus, then through the Johnson procedure, and we successfully revert the uterine inversion. And sometimes if we are failed to do this, then we jump towards the second maneuver, that is the O'Sullivan procedure. And in this we are not commonly perform this procedure. In this procedure, a normal saline, 2 to 5 liter of normal saline, that was with the help of a elastic cup that we are putting it inside the vagina, and we squeeze the vulva with the help of our other fingers, and we insert a pressure of about then we insert the normal saline from a height of a meter. So with this normal saline pressure, free pressure, the uterus will be moved towards its original position, and we call this maneuver as a O'Sullivan procedure. Next comes, and sometimes we need a certain operative procedure. We need to do that called as abdominal procedure and some vaginal procedure. The abdominal procedure is Huntington and Holton, and the vaginal procedure, you will see that where is the dimple. Then from the side of the dimple, with the help of the Ellis forceps, you are going to revert the uterus back. This is called as a Holton. In case of the Huntington procedure, we open the abdomen through the transverse incision, and then we give vertical incision on the posterior side of the cervix, and then we will revert the uterus. But hardly we jump towards these procedures. Most of the time through the O'Sullivan procedures, and we revert the uterus. We are successful in reverting the uterus. Okay, and now next comes the complications. The complications include the postpartum hemorrhage. It could be due to shock, it could be perinatal morbidity, it could be endometrial sloughing, or sometimes the pulmonary embolism. Okay, are you with me? Can you repeat it for
Yes.
me? Any complication?
Uterine morbidity and mortality, and there can be uterine endometrial sloughing.
Okay, that's good. You are a very good learner. And now can you tell me how was my session? Do you have any benefit of this?
Yes, it was very good, and I have learned a lot from this.
Okay, thank you.
Thank you
I'm
so
giving
much.
you some links, and I'm giving you some links, and I will suggest you that you will visit the labor room, and if next time the emergency will come across in case of uterine inversion, then you will be a very active participant of this. Thank you.
Thank you so much.
Okay.
Dr. Lubna?
And at the end, madam, I will have to do the documentation, debriefing, incident reporting, and duty of condor will also be done. Sorry, I forgot.
Okay, you have 2 minutes. That's why I have given you that if anything you need to cover, you can cover it. Otherwise, I will ask questions.
Madam, you can ask question. I have finished.
Okay. First I will ask questions about the session. Okay. Tell me, you said that it is the chances of immediate reduction are after manual reduction. What are the chances of immediate reduction?
Immediate reduction, chances of immediate reduction.
Yes.
Madam, I said 90%.
Okay. Then I will tell you it's not right. Okay. And the need of surgery?
Need surgery, less than 3%. We need, we move towards hysterectomy.
Yes, it's less than 3%. Okay. And you were using vaginal procedures also. What are those? And do we do RCOG recommend those?
Vaginal procedures, madam. This is the Spinelli and the Costner procedures in which we do the anterior and posterior colpotomy will be done.
And does RCOG recommend them?
Madam, I don't know exactly.
Okay. Okay.
I think both recommend it.
No, RCOG don't recommend them. They are in much more.
No, absolute, not recommended, madam.
Yes, they are not recommended now. Okay.
Ma'am, it is written that if the hydrostatic and conservative management does not successful, then we used to go to the laparotomy and even the hysterectomy, and there is no role of the colpotomy interior or posterior.
Yes, exactly. Who has given this answer?
Dr. Iram.
Dr. Ram, you are exactly right. Now the vaginal procedures are not recommended. So it's better not to use them, not to use those terms which are not recommended nowadays, okay? Okay. Now, if the time will be up, you can join me with the same link. Okay. First, I will give you review about Nazish. Okay. As Nazish has presented the case, the time management was good, and you started with the definition. It was good, but you spend little more time on the definition. Try to be fast, Nazish. You have to learn by heart that what is the definition, what are the types, like that. ठीक है? उसके बाद you were haphazard. You were not going stepwise. First we move to the definition, then you tell about the manual replacement, and then you tell us about the communication and resuscitation. So first is the communication and resuscitation, okay? And you mentioned the enhanced recovery program. It was good. You tell about the complication. It was good. And you mentioned that less than 1%. I think you have tell the percentage wrongly. So try to remember the percentages very well. If you don't remember them, don't tell. Okay?
Okay.
Telling wrong is मतलब उनको पता चल जाएगा you don't know. तो बेहतर है जो चीज आपको नहीं आ रही आप उसे मत बोलें. ठीक है? अच्छा, लुबना, your time management was good. You tell about आपने स्टार्ट से ही लिया, आपने इंट्रोड्यूस किया, एजेंडा के बारे में बताया, एंड ऑफ सेक्शन के बारे में बताया, ठीक है, एटियोलॉजी के बारे में बताया. यू वर गोइंग विद द फ्लो. ठीक है, आप स्टेप वाइज जा रहे थे. आपने आखिर में पोस्ट ऑफ मैनेजमेंट क्लिनिकल गवर्नेंस इसके बारे में नहीं बताया. ठीक है, और विजाइनल प्रोसीजर जैसे मैंने आपको बता दिया कि जो चीज नहीं हो रही, ऑब्सोल्यूट हो चुकी है, आप उसे ना बताएं तो बेहतर है. बाकी एज योर विश. कुछ चीजें मैं आप लोगों की नॉलेज में ऐड करूंगी. मे बी यू नो मच. यू डोंट हियर मी?
No, madam, we can hear you.
Okay.
जी मैडम, you're audible.
ओके, तो कुछ चीजें मैं आप लोगों के लिए ऐड करती हूँ आपकी नॉलेज में. आई नो यू नो बेटर देन मी बिकॉज यू आर just nowadays you are the students who know you are who are reading each and every article and everything. तो इसको अगर आप इस तरह से ये चलें, look at this.
मैंने चपाल की साइड पे कर दिया, मुझे कहती है 100 थप्पड़ मारा.
Mute all. I am muting you all. Okay.
टूट गया.
Okay. Now check for bullying and undermining. Aim of the discussion: check background knowledge, set agenda, like Lubna has done. Then tell about the definition, types, etiology and risk factor, clinical presentation, DDs and management. And then in the management, first step is the communication, then resuscitation. And then prerequisites, manual replacement, then hydrostatic method, surgical management, Huntington and Halton's operation, recent technique you both have missed, then post-op management and clinical governance. इस तरह से आपने ना स्टेप वाइज चलना है. इसे आप बेशक स्क्रीनशॉट ले लें आप लोग सब, या अपनी कॉपीज पे लिख लें. इट विल बी हेल्पफुल फॉर यू पीपल. ओके, तो ये मैं आपको सब कुछ पढ़ाऊंगी. आई वॉज जस्ट टू टेल यू फॉर द टीचिंग स्टेशन कि इस तरह से आपने चलना है. फर्स्ट आई वॉन्ट कि हम इसी के साथ जो अपने दूसरा हमारे स्ट्रक्चर डिस्कशन है उसको भी कवर कर लें. ठीक है, तो who are willing for the structure discussion?
मैडम मैं करूं?
कौन, लुबना?
जी मैडम.
और कोई विलिंग नहीं है यहाँ पर? इट्स गुड यू आर एक्टिव, और ये आपको बहुत हेल्प करेगा एग्जाम में. क्योंकि जितना आप गलत करेंगी ना, वहां आपको याद आ रहा होगा कि हाँ मैंने ये भी मिस किया था, एंड इट विल हेल्प यू अ लॉट. और अगर ये केस आ गया, इट वाज द क्वेश्चन ऑफ जुलाई 2022 क्वेश्चन एंड अगेन रिपीटेड.
लास्ट ईयर भी रिपीट हुआ है, ये
लास्ट ईयर भी रिपीट हुआ है, तो ये रिपीट हो रहा है तो अच्छा है. अगर आपका बेटर नॉलेज और आपका ही केस बन जाए तो आपको याद रहेगा. ठीक है, तो जो भी करना चाहे तो बेटर है. तो कौन करेगा अभी? जिन्होंने कर लिया वो अगर ना करें, और जिन्होंने नहीं किया वो कर लें तो बेटर है. अच्छा है, सबको चांस मिल जाए.
मैडम मैं कर लूँ डॉक्टर इरम?
ओके
हाँ,
राम
आप कर।
स्टार्ट करें, ये रीड करें जोर से क्वेश्चन.
You are the registrar in charge of the labor ward. You are urgently called by the midwife. She has just delivered a patient who had a vaginal delivery and has collapsed. You arrive in the room and the midwife is there with the uterus inverted and placenta attached. The examiner will ask you a series of 4 questions about the management of this patient. You will be marked on your ability to answer these questions from the examiner with regard to the emergency outline.
Okay. Shall we move
Madam,
to the
I am
questions?
Dr. Yeah.
Okay.
Madam, I have read the scenario. Madam, I am Dr. Iram. I have read the scenario and I am ready for the structured discussion.
Good. Start your question. What will be your immediate management?
What will be your immediate management action on being faced with this case? As it is in, madam, as it is an obstetrical emergency, first of all, we will have a communication with the colleagues in the redeposition of the uterus is my next step. I will tell my junior to take the vital signs, which most importantly include the pulse rate. As it is in a situation where there is a neurogenic shock, the patient can have the bradycardia proportionate to the hypotensive condition, in which condition I need to give the atropine to the patient. What other step would you taken in the management of this patient? My previous maneuver, which was the manual redeposition or Johnson method, can be failed. After which I can do the other maneuver, including the hydrostatic or O'Sullivan method, in which I will put a elastic cup in the vagina and make a C shape of my left hand in order to prevent the slippage of the water, and will attach the drip set to the elastic cup from the height of a meter or two to revert back the uterus inside the normal anatomical position. If both of these conservative management is failed, then I will proceed to the laparotomy, which is the chances of which is about 3%, where I will proceed abdominally and will try to reduce the inverted uterus by Huntington procedure. What risk management issues is important here? First of all, I will debrief my patient about all of the condition that has been occurred. Will also have the duty of condor, and will also arrange the simulated workshop and drilling in my ward in order to teach the juniors about this obstetrical emergency. Hello.
Postnatal management